Thank you, Patrick, and thank you, Andy, for inviting me out. So, I have nothing to disclose, unfortunately. Today we're going to talk about radiofrequency ablation as one treatment modality for benign thyroid nodules, typically. So, we'll talk a little bit about indications, the technique, the knowledge base that you need if you'd like to embrace this technology, setting up your own RFA practice, what I learned, and then we'll conclude. So, RFA is typically used for what they call symptomatic benign thyroid nodules. And I will be coming back to symptomatic all the time because this is an interesting, albeit subjective point. So what is a symptomatic thyroid nodule? Often we talk about compressive symptoms. That is, the patient will complain of experience neck fullness or discomfort, globus sensation. And there really is no good relationship between how big a thyroid nodule is and whether it disturbs someone or not. Other things are cosmetic concerns, meaning they don't like the way it looks, it protrudes out of their neck, whether you see it or not. Thyroid nodules that continue to grow. Anxiety, not being able to sleep because you're afraid it will become a cancer. Which is not really realistic, but we're not in the patient's shoes, and a toxic nodular goiter or a functioning nodule. So the treatment for thyroid nodules has traditionally been observation, or what's now called active surveillance, surgical resection in the form of usually of a hemithyroidectomy, radioactive iodine to destroy the toxic nodular goiter, or TSH suppression in some cases. Minimally invasive techniques that were used more often in the past were ethanol ablation, whereby you take a cyst and you inject ethanol and it stops secreting. So the minimally invasive techniques of today are all thermal in nature, and they include laser ablation, and this is performed via a needle and fiber optic using a ND-YAG or a diode laser. And this is currently in the world the second most common used thermal ablation after radiofrequency ablation. What is becoming more popular in Brazil and in Europe is microwave ablation. And this creates more heat and a larger zone of destruction. And there's also high-intensity ultrasound, which is the least used technique today. Radiofrequency ablation is which is the most common in the United States and what I personally use. What it does is it uses a low heat to destroy the targeted, it's not really diseased tissue, it's, because thyroid nodules are common and natural. I wouldn't call them diseased tissue, but I'm calling them diseased tissue. And what it does is it's a high-frequency alternating electrical current which oscillates between 200 and 1200 hertz. And this causes there to be heat adjacent to the tip of the electrode. There's also some propagation via conduction, so this continues to kill off tissue in the adjacent area, and you have to take that into account. Now, I said that it oscillates between 200 and 1200, and if you take a look at the way this works, there's a circuit with the patient being part of the circuit, but this oscillation occurs too quickly for them to become electrocuted, thank goodness. It has to reach a certain amount of temperature for it to actually be irreversible damage, which is what we want. There is then coagulation, necrosis, and then the body evacuates the debris over time. So it's really important that this does not occur right away. So we started talking about indications. So benign thyroid nodules is by far the most common indication. Autonomous functioning nodules as well. nodules that continue to increase in size, and malignant tumors which deserve their own slide or two. The problem is that these symptoms are incredibly subjective, and you have to take that into account. Now, we've all had patients who walk into the office and they have globus sensation, and you see that they have a half-centimeter nodule, and they, in their mind, attribute their globus sensation to that nodule when we know that that's probably not true. So you really have to understand, and you have to be convinced that the patient's symptoms actually have something to do with their thyroid nodule, because there are no strict criteria. And if you take a look, if you watch the literature over time, guidelines have become, all the rage, and every society is churning out papers with their guidelines, and sometimes they contradict each other. For instance, for RFA, the Korean society, and like many other technologies, the Koreans have, championed this, and they talk about a nodule exceeding 2 centimeters, while the Italian society, also a group that uses RFA and has been using it before the United States, they talk about 20 milliliters, volume. So you have to elicit the symptoms from your patient, and you have to be convinced that those symptoms have something to do with their thyroid nodule before embarking on this. Otherwise, you will be disappointed, and more importantly, your patient will be unhappy. Cosmetic concerns, again, incredibly subjective. Whether, there are patients who walk in the room, and, when you've been doing this a long time, you instinctively look at people's necks. I look at people's necks and airplanes and that, And so, I know. So, the patient sees it, you have to be able to see it as well. So what is a benign nodule? There's a little bit of controversy here, because many of the people doing this will insist on 2 benign biopsy results, either core or FNA. But again, the guidelines differ. And again, I would say I have to be convinced that this is in fact a benign thyroid nodule. So oftentimes a patient will come in with a biopsy from a remote area, and if I don't trust this, I will get the patient another biopsy in my institution where I trust my pathologist to do a good job. And it can't be a biopsy from 3 years ago as well. So a current biopsy that I'm convinced is benign is good enough. Some people ask it. Now, if you have patients, occasionally a patient will come in and they have a suspicious looking thyroid nodule. And you really have to be convinced that, even though there are those who treat microcarcinomas, you want to know that you're treating a benign nodule. You don't want any surprises. RFA is excellent for benign nodules, and there's typically reduction of volume in non-functioning nodules up to 85% within a year. So again, this does not occur overnight. LIMS study showed that there was a 93% volume reduction at 4 years afterwards, because they asked, is it going to grow back? Typically, it's destroyed, it gets smaller, and it does not grow back. There's absolutely a lot of papers that come out that say smaller nodules obviously do better. And this is going to be kind of an issue, because like when I started, I was trying to do 7-centimeter nodules because I didn't want to hurt the patient. You always try with start off something new with great candidates. Turns out that 7-centimeter thyroid nodule, if you do RFA once, will probably turn into a 6-centimeter thyroid nodule, which is still pretty big. Thyroid cysts are excellent for RFA. I'm sure you've all had patients who come in, to the emergency room with a big thyroid cyst, and these things can grow very large. One of your residents aspirates it, the patient feels great, and then 2 days later, they're back in the emergency room because that really doesn't cure it. It reaccumulates. With these, and I'm reminded of the excellent talk yesterday where they showed pulling a huge snot ball out, which was very satisfying. So this is what thyroid surgeons find satisfying. Here's the aspiration. Come on. Cannot play media. That's not good. Oh. That's unfortunate. That's not going to be good. All right. This is the aspiration of a cyst in video. Wow. Is it playing?
No. It says it cannot play.
Wow, all right. Sorry. All right, another indication is autonomous functioning thyroid nodules. So patients come in with a toxic single nodular goiter, and they are not suitable candidates for surgery, or they refuse surgery, and they don't want to get radioactive iodine for multiple reasons. And there are studies out there, multiple studies, that show that this is an excellent technique for destroying a functioning nodule. One group found a greater chance of thyroid function normalization and resolution when the volume has been reduced about 80%, which you can absolutely do with a 2 or 3 centimeter nodule. There are other groups that have shown less compelling results. In my practice, most of the patients who have had this done have responded nicely, and the nodule stopped functioning. These are a couple of studies out there showing varied results when it comes to RFA for a toxic, for an autonomous functioning thyroid nodule. Now let's talk a little bit about RFA for thyroid cancer, because this is controversial, but it's coming up. So, you know, the guidelines of the ATA suggested active surveillance as one option for small, low-risk micro papillary thyroid cancers. So then the question arose, if I can watch it, why can't I try and treat it and watch it? And it makes perfect sense to me. So there's a trial now that Dr. Russell's doing out of Hopkins, and in other countries this is done routinely, where small thyroid cancers are destroyed using radiofrequency ablation. To be fair, there are some studies out there which say that subsequent surgery may be needed because of incomplete response. So the jury's still out. It is certainly an option for small cancers. Now, what is our protocol? So we said biopsy. Got to make sure I'm convinced that this is benign if I'm doing it for a benign disease. Obviously, if you're doing a microcarcinoma, you have to know that as well. Typically, I look at my own ultrasounds. I want to be convinced that this is something that we can do. The patient is, blood tests, usually most of my patients come in with a TSH, because at least in my practice they come in through the endo door, but if not, it's probably wise to have a TSH on file to make sure you're not dealing with a functioning nodule. And the procedure is done in my office. In like Brazil, for instance, they are compelled by their health system to do these in the operating room, which kind of defeats the purpose, because this is an absolute something you can do in an office. It's done under local anesthesia, mild sedation. At first, when I first started, I offered the patients, if they wanted an Ativan, they could have one. Now I say, take an Ativan. For me. Hydrodissection, which I'll go into. We also use regional anesthesia and specialized electrode, which there are multiple vendors out there who sell these. I don't work for any of them. And so the basic technique is you give an injection in the middle of the neck over the isthmus of the thyroid, and then we use something called a transisthmic approach and a moving shot technique. There are more advanced techniques using hydrodissection to move a nodule away from, or move the nodule away from vital structures, to use it kind of as a hydro buffer. Not often necessary, but sometimes. I'll go into that a little bit more, and then you have, so I'm going to say this multiple times. It is imperative that you visualize the needle the entire time. I don't have to tell you as head and neck surgeons that there's a lot of important stuff around the thyroid gland, like the trachea, the recurrent nerve, the vagus, and the great vessels. And you must have your eye on the needle the entire time you're doing this procedure. This is this a laser?
You can use the mouse.
I can use the mouse. So this is your airway over here. This is a big old thyroid nodule. Here's your common carotid, your IJ. And this is known as the danger triangle. This is where the recurrent laryngeal nerve is, and we do not ablate in that area for that reason. The basic technique is transisthmic. So we actually stick the probe through the isthmus of the thyroid gland. We don't come in from the side. It is considered less safe. Sometimes, I will be honest, I'm saying to myself, I can get to this from the other side easier, but I've not done that. This is a transisthmic approach. And what we do is we start ablating from deep to superficial and from medial to lateral so that the trails of the heat, and you'll see them, I'll show you, hopefully the video will work, the trails don't obscure the rest of your ablation. So it's done in a systematic fashion. Now, radiofrequency ablation was not invented by us or for us, and it's been around for decades. As head and neck surgeons, we do very little having to do with the liver or pain management typically. So liver surgeons and liver doctors have been using radiofrequency ablation for liver cancer for many years. And what they do is they do the one-shot technique. So they'll stick the needle into the lesion in the liver, turn up the heat, go smoke a cigarette, come back, turn off the heat. And that's the ablation. That's one shot. Sometimes they'll do multiple shots, so they'll put it in different areas. Again, turn on the heat, leave it alone. In the thyroid, we use something called a moving shot technique. And this is where you ablate while withdrawing the needle through a certain area to get the entire nodule. And this, again, is considered the safest. So the moving shot technique, you stick the needle in, and you will see something called budding and blooming when you turn the heat on. And you have to tell your patients that they may hear crackling, because you actually will see little bubbles as you withdraw the needle, and that's how you know that you've ablated a certain section. You can also look at the impedance on the machine, and we have someone watching that. So this is budding and blooming, and tell your patients that there will be crackling, and all right. Let's see if this works. Cannot play video. That is really unfortunate. All right, I apologize, guys. I was going to show you budding and blooming. Positioning the patient and positioning yourself. This is done in clinic. The patient is lying flat for the most part, or your dental chair reclining, and you sit behind the patient. I don't know if you guys saw at the Academy, there were a couple of really wonderful talks on ergonomics in surgery. So we're paying attention to how we are in relation to the patient so that we don't hurt ourselves, our neck, our arms, and so on and so forth. So the patient position is really important. You're going to be sitting for 40, 45 minutes behind the patient. Although it's not painful, I tell the patient that it is intense, because they're lying there and you have your arms around them and you're looking at an ultrasound machine, you have a needle in their neck for about 40, 45 minutes. So it is intense. When I started doing these, I was standing, I was leaning, and I felt it afterwards. So you really have to get the positioning correct. You have to be able to see. This is from my friend Leo Rangel in Rio de Janeiro, who's been a great mentor to me, and I've watched him do this down there. And you have to be able to use both hands. You have a probe, you have a needle, you have a foot pedal, and you have to watch the ultrasound machine and make sure your patient's okay. So it's important that you figure out how to sit comfortably. Oh, this one's working. We measure. First thing we do is we measure how big the nodule is, because that impacts where we're going to place the needle through the isthmus. Because sometimes you'll have a huge nodule and it's pushing the entire isthmus over to the opposite side. And midline is not really midline, or at least not at the beginning. So we measure this, then we do our local anesthetic, and then we make a little stab wound with an 11 blade. I don't know if there's a better word to tell a patient. I don't like saying a stab. When we say I use an 11 blade, I make a little stab. I'm trying to figure out a better word to tell the patients when I explain it than stab. So then you make a little incision, and that's where you're going to insert your needle. So the measurement is really important. Then we do our regional anesthesia. Regional anesthesia means that we insert the needle. So the thyroid gland itself does not feel pain, but the thyroid capsule, like many capsules, will stretch, will change, and that is where the patients will feel any pain if you don't give them adequate anesthesia. So the out-of-end makes them calm. The local is just for you to be able to continue on and to make your little pinprick incision, but you need to give them regional anesthesia. And what we do, this is perithyroidal anesthesia. We insert the needle in between the strap muscles and the thyroid capsule under ultrasonic guidance, and we then inject lidocaine there. And what you can see here, I suspect my video unfortunately will not work, but what you can see here is you see the needle here, and this space over here is an area that has been injected. So you have your strap muscles here, and you have your thyroid capsule below, and here's your thyroid nodule. And once you see that, you know that you've done a good job. Here's another one as well. So with the needle in, and this white is superimposed. This is the lidocaine. No, won't play. I'm sorry. All right, anyway, surprisingly excellent anesthesia. Patients, if you do this correctly, do not feel the procedure. It's not painful. So, transisthmic, right? Know your anatomical landmarks, going through the isthmus, and then you go, like I said, from deep to superficial and from medial to lateral. And stay away from the danger triangle, which you can see. What we do is we go in, and then after you're finished, so you've divided this into tracks, you go in an orderly fashion. At the end of the procedure, you take the probe and you look laterally, and then you see slices. Is there an area that I did not ablate? And you can go back and ablate that area. Like anything else, the enemy of good is better. So you have to understand that the idea is first and foremost not to hurt the patient. And typically if you do an 80% ablation, you've done your job. Certainly you don't want to hurt the patient. Here's a couple of stills, unfortunately, that show here's your thyroid gland, here's your danger triangle, and the esophagus, your airway, and you place the needle in, and again, from deep to superficial, from medial to lateral, and then the area is ablated. Here's a schematic also, just to make it very clear. So here's some tips for beginners. I don't know if it's just me, but as a surgeon, I'm an impatient individual. And this is something that requires a little bit of finesse and a little bit of time. So my inclination, like the Bovie, is turn it up to stun and let's burn this thing. Doesn't work like that. Rangel told me it's like a steak. You do not want to overcook the outside. So think about it. So it takes a little bit of time. Lower wattage is better to start with. The problem is that you'll learn over time that not all thyroid nodules behave the same when you ablate them. Some are denser than others, right? So sometimes you need to turn up the heat, otherwise you don't get the result you want. It's something you learn. Don't start off with 7-centimeter nodules like I did. It was a mistake. So this is something that people in Korea told me, never do this more than 20 minutes. And I say, kudos to them. I cannot do this in 20 minutes. It takes me 45 minutes, and the patients don't complain. Under-ablate rather than over-ablate, so you don't hurt the patient. And yeah. Cystic nodules, like I said, I wish I could show you the feeling of aspirating gunk from a cystic nodule. They respond beautifully. What you do is you collapse it, and then you burn the collapsed walls, much like a deflated balloon, and they will not reaccumulate. I did this last time to one of our administrators, and she's a happy camper. Advanced techniques are hydrodissection. This is something, if you have a nodule that's sitting right next to the carotid artery or right on the trachea, you take a dextrose solution. You don't do this with lidocaine. And what you can do is you can stick a needle in and then lift it up off of the danger structure or move it away and make an aqueous barrier. Let's talk about complications. Complications, I tell my patients, are the exact same complications that you can get from a thyroidectomy, only a lot less. There are, however, complications that most thyroid surgeons will never encounter. even if they're not good thyroid surgeons. So Horner syndrome, okay? If you stick your needle through the thyroid and you go deep to the thyroid, there's a lot of really important stuff that we don't typically encounter during thyroid surgery. You shouldn't encounter. So hematoma. So, you know, that dreaded hematoma of a thyroidectomy, part of the problem is that the thyroid is gone, so that space fills up with blood. This is not the same hematoma. Fortunately, I've not had it, but, you know, when you do your ultrasound beforehand, you want to make sure you're not sticking your needle into a huge vessel. That's just common sense. I have encountered what's called a vasovagal response, for those who have not seen, and you know, where patients say, I'm fine, or I've had a husband faint on me too. I let the husband or the wife in the room. Maybe I shouldn't. So, you know, all of these are potential complications, and if you're going to do this, you need to know how to deal with it. I put an ice pack on the patient for their comfort. If there's a little bit of bleeding from that little stab wound, pressure is enough. What happens if you have nerve damage? Like the patient suddenly is hoarse, or their pupils are, you know. So I've not had to do this, but the conventional wisdom is that you put the probe back and you inject cold dextrose into the area that you damaged. Again, never had to do it. Follow-up, patient gets Tylenol or Advil. Sometimes they feel a little swollen because I've been plunging a needle into their neck for 40, 45 minutes, so the next day they feel beat up. My PA will give them a call, how you doing? Usually there's no problem. At first I was seeing these patients monthly, and it was frustrating and it was stuffed up. Now I see the patients at 6 months with an ultrasound and at 12 months with an ultrasound, and they're told up front this will not happen overnight. That being said, I am willing to take credit for anything good that happens after a procedure, so if the patient feels better after a month, you know, I'm happy to take credit for that. But typically 6 months is when you want to look at them. So how do we set up, am I okay for time? Okay. Not having the videos for it. So how do you set up an RFA practice? I brought this up thinking this may be helpful for you who want to. So first and foremost, you need, so the instruments are not expensive. The ablation machine costs about $29,000. My ultrasound costs a lot more than that machine. You need to have buy-in from stakeholders, so your chair, your administrator. So this is really important. Why is this important? Why do I want to do this? Why do I want to offer this? You need an ultrasound machine. I learned that a good ultrasound machine is even better because I got one in the midst of it, and it's like, wow, this is awesome. You really have to feel comfortable doing interventional ultrasound work in the thyroid. You can really hurt someone if you don't. Surgical judgment, as always. This is one tool in a thyroid practice. Not everyone who wants this is going to get it. Never let yourself be bullied into doing a procedure that you think is wrong. I'm sure I don't have to tell you guys that, but I'm going to say it anyway. Hands-on courses and a couple of proctored cases are probably wise. A lot of chicken breasts got ablated by me before I started doing this as well. So again, one tool. Patients come in, I read on the internet that you do this and they have, you know, a substernal goiter that's reaching their heart. No, ma'am, this is not it. Or they come in and they say they have terrible globus and then you look and their thyroid nodule's 1/2 centimeter. I'm sorry, this is not causing your discomfort, okay? So administrators, you have to do that. Your chair or your boss or whatever. Coders, billers. I had a long conversation because this does not reimburse equally across the United States. Referring physicians. I went out and I shook hands and kissed babies and gave lectures to endocrinologists, which bolsters your thyroid practice overall, and said this is another technique that we're offering now. And you have to have space to do this. So, or I said this, so I made it big. Make sure you're skilled at using a needle in the thyroid. These are the generator that I use. So right now, there's no billing codes for RFA of the thyroid gland, okay? So these are the codes that we use, and I was telling Andy last night that so I'm the only one in the Commonwealth of Pennsylvania doing this currently, and using these codes, this reimburses gangbusters, okay? Anywhere between $9,000 and $21,000 a pop. My friend at Hopkins, Dr. Russell, takes cash up front from patients because the insurance there are denying these right, left, and center. So it's really, really important that you do your homework to make sure that you're not doing this as a losing endeavor. Certainly as an academic, I'm not in this for the money, but still, it's a lot harder to convince, to convince the people who are your administrators that this is going to be something that's viable if you're going to lose money every single time. And some people do this like cosmetic surgery where they demand cash up front, and if insurance pays it. We have not had to do that. I know it's only a matter of time until a code comes out, and it's going to be whatever it is. For this, documentation is imperative. You cannot, I do not bill for the ultrasound. If you bill for the ultrasound, you have to store the images, you have to save, you have to measure. And as you know, every code you add, you get paid less and less for everything. So I don't, but you have to know the rules and regulations so you don't get yourself or your team in trouble. Another thing is I bill for the regional anesthesia. It's called a cervical plexus block. This is the code, and it's completely kosher to do so. So those are the two codes that I bill when I do this procedure. This is my note. I'm not going to read it to you. It is succinct, but it covers all of the bases as to what I've done, both from the patient and to satisfy the coding and the billing needs. And I've gone over this multiple times, multiple iterations, and this is the way I use it every single time. This unlisted code is not covered by multiple insurances, and you need to get your pre-certification people involved. What is your place of service? Is it hospital billing or not hospital billing? Also makes a difference. So here's some lessons that I've learned. I've been doing this now for about 3 years. Make sure the patients understand their expectations. Does not happen overnight. Remember that your patient is awake the entire time. They may be snowed, they may not be snowed, but they're awake. And I'm a head and neck surgeon, and as a head and neck surgeon, there's a certain expectation, even as a thyroid surgeon, of a population. And the population that have been coming for RFA have been more like a cosmetic practice. And I learned this. I mean, this is me, just my understanding of it. My nurses and PAs have turned the suite into a spa. There is aromatherapy. We got little blinders to put on the patient's eyes that say otolaryngology head and neck surgery that we give them. We bought a squeaky ball so that when they swallow, they will squeak so I can stop the procedure. So if a patient swallows when you have a needle on in their neck, it's not what you want. So you say to the patient, if you need to swallow, raise your hand. So I've had a lot of patients who have swallowed and then raised their hand, which is not what we were trying to do. So we bought them a squeaky ball. And these are all, and truly it has turned a part of my practice into something that was never there before. There's classical music playing in the background. It's very, very calm on the awake patient. Like I said, my friends in Brazil are doing this in the operating room. So this may be different for you. This has been my experience. Patient neck extension is important. If you have a patient who is completely kyphotic and can't move their neck, you cannot do this safely on them, just like you wouldn't do thyroid surgery on them without taking that into account. Indications, one last time, it's very, very subjective, but I urge you as the clinician to be convinced that this is the right thing to do for that patient and not let the patient think it is because they read about it on the internet. Therefore, the ideal candidate is someone with well-defined dominant nodule and that everyone's convinced that this is what's causing the patient's concerns. And I am convinced that selection criteria will expand over time. If we meet up in another 5 or 6 years, things may look very, very different, like anything else. So, in conclusion, setting up an RFA practice is complex but not insurmountable. Financing, this is not crazy expensive to do. Buy-in and cooperation are key. Training and practice are key. And this is just another tool. If anyone wants to learn to do this, we are giving a course in Rio de Janeiro in a couple of weeks. It's nice this time of year. And we'll probably be offering our course in Hershey, Pennsylvania, the first 2 days of June. It's also lovely in Hershey at that time. We do a little reception in the Rose Garden at the Hotel Hershey. So thank you very much for your attention and for inviting me.